So Michelle, you can start the recording. So we're going to start our session now on bearing witness to lived experience. As I noted, we have several learning objectives today to learn best practices and methods on how to share and receive stories. I'm Carrie Koleski. I'm a research chair in patient and family-centered care at the Institute for Better Health at Trillium Health Partners, and also an associate professor at the University of Toronto, who I work in partnership with communities, patients, families, care providers, leaders in our system to learn how we could improve healthcare and how we can better work together. So Michelle, you can go to the next slide. And so take this opportunity to introduce yourself in the chat. You might be part of an Ontario health team, and maybe you're not. So tell us where you're from, tell us the role that you play if you want, if that's applicable. And again, we're recording the session, so just keep your videos on mute. You're welcome to come off at any time, but the recording will pick up the view of your video. So take this opportunity to introduce yourself. We'll have opportunities to interact a little bit later in the session. Over to the next slide. And we have started a library of resources, which I'm really excited about. If you go to YouTube and type in patient experience team, you'll find the two resources that we've posted so far. We have a overview of core engagement principles and co-design. It's kind of like a foundational video that you could watch, which is about 45 minutes long. We also have the first session taped and put on YouTube as well on communication, compassion, and empathy. And this first session is really critical because it gives you sort of the core elements of how to create an open environment for conversation, how to respond in a way that doesn't shut down conversations, but keeps the conversation going. It digs into what empathy means versus sympathy. It has a really nice video link from Brene Brown to, in a very creative way, share what we mean by empathy. And also there's some tools that you could use with your teams to learn how to have those open conversations with one another. We have a workbook from the first session. We also have a workbook from this session today that you can go and practice and do things with your team afterwards. If you don't have that workbook, you can put your email in the chat and Michelle will send you the workbook from both the first session and the current session going forward. On to the next slide. And I'm going to start with a land acknowledgement as we launch into the content for today. And I have both a land acknowledgement and an African ancestral acknowledgement, and it is Toronto-based because I'm joining you today from Toronto. We acknowledge the land we are meeting on as a traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. The City of Toronto acknowledges all treaty peoples, including those who came here as settlers, as migrants either in this generation or in generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. We pay tribute to those. Can you scroll up, Michelle? And so we pay tribute both to the Indigenous people who came here before us, as well as our individuals who came here as settlers and migrants. So on to the next slide. So this is to really set the tone for the topic for today. I'm going to start with 3 quotes to ground us, to really think about what we mean when we talk about patient stories. So Jennifer Schipper, who's the former chief of communications at HQO, said, patient stories offer valuable insights that go way beyond the statistics and the outcomes. They have the power to inspire, humanize, compel action, and challenge assumptions. Next slide. Ross Baker reminds us to think about stories, in a kind of a different way. He said, well, the big issue is how these stories are actually used, what people do with them. How do they actually affect change? And he also cautions by saying there are some emotional issues and potential psychological trauma that occurs from re-experiencing events. On the other hand, you could argue that bigger damage may come from people who feel like they went through a bad experience and nobody cares. So there's a whole science to sharing and receiving patient stories and lived experience. Next slide. Also want to draw your attention to the workbook, which will help you continue your learning after today's session. There's practical tips for the person telling their story as well as sharing their experience. And we've used that interchangeably. Some people don't like to say telling story. They prefer to say sharing experience. But for the purpose of today, we're gonna refer to it as storytelling and sharing stories. There's guidance in the book for those who are hosting and facilitating meetings and supporting people in sharing their lived experience, as well as a bunch of tools and checklists and links and some of the resources from other OHTs who generously shared with us what they've put together related to this topic. On to the next slide. And so I'm already behind schedule. Not much of a facilitator here, but I will try my best to move things along. In a couple of seconds, Michelle is going to launch a poll so we can get a pulse for who's in the room today and some of your experience in this topic. I'll review the session relevance. I'll get into a theory burst, which is a backgrounder on the topic, and I'm going to launch what's called a Mentimeter. So some of you may be familiar with that, and we used it in the last session. It's basically kind of an online tool that's free, anyone can use, and we'll give you a link to join the Mentimeter and answer a few questions. We're then going to move into a panel, and I will introduce the panel as we move to that point of the session. And you can put your questions in the chat box. I have a couple of prepared questions to get the conversation going, and then towards the end, we'll move to the chat box. Then we're going to move into breakout rooms to kind of dig into the content that we covered today, and then have some wrap-up questions and reflections after that. So with that, Michelle is going to launch a poll. There's two screens, or two questions rather, for this poll. So the first question is, do you have experience sharing your story or hearing someone's story in a formal setting? So a team meeting, a steering group, an activity. So it looks like, from what I can see, the large majority of people have had experience either sharing or receiving their story. Okay. So I think, Michelle, in the interest of time, we can launch the second question. So we can actually share the results of that quickly. I'm assuming people can see. So we have 92% that yes, have some experience sharing or receiving a story, and a few 8% that don't. And this is great. This is a great place to start and a great place to grow from the knowledge that we might have. Okay. So next question. So we can launch the next one in the poll. And what is your role and within the OHT? I know not everyone's from an Ontario Health team. So you could just answer whether or not you're a patient or caregiver partner, or fulfill another role, which could be a provider, a staff member, facilitator, community leader. And I apologize, I know that's a very broad category, but we are interested to see kind of the difference between patient caregiver partner and people who are more in roles that will support patient caregiver partners. So it looks like we have a pretty even split from what I can see so far. Okay, so I think we will end that poll. So we have 45% patient or caregiver partner and 55% people who are in other roles that are not considered patient or caregiver partner. I know people occupy many roles. It's what you primarily identify with. That's what we're looking for. Perfect. I'm assuming people can see those results. We have 45% patient or caregiver partner, and OHT staff or other, we have 55%. Okay. So we can move along to the next slide. So the session relevance, why are we here today? Why does it matter? And, and clearly from the poll results, people have had this experience of sharing or receiving stories, but in our healthcare system, it's becoming more and more popular and sometimes expected to share a patient story or to share those lived experiences. It might be used to open up a board meeting, a planning meeting, a steering group. But sometimes it happens sort of as a staple item on the agenda without really thinking about, why are we doing this? Is the person sharing their story, have we given them the tools and the space and the safety to share the story? And also, as recipients of the story, are we doing this in a way that is open, respectful, and supportive? Have we learned how to do that? And sometimes we put it on the agenda, but we don't think about the implications of having the story as part of our meeting. So there's high risk of tokenism and other poor outcomes if the person sharing the story and the people receiving the story are not adequately prepared and supported. So learning how to share and receive stories is important for us to work effectively together in all of the engagement activities we do, whether it's co-design, a steering group, a decision-making council of sorts. Anything we do together as a group, it's really important to learn how to share, how to receive, and how to best prepare ourselves for those activities. On to the next slide. So now we're going to move into the theory burst, and I do encourage people to put questions in the chat. We will get to it after the panel, but I do want to loop back and make sure that I'm answering questions of people in the session. So why share stories? And, we share stories with purpose. And I really want to emphasize, I was talking to Lori Malton, a member of our panel and patient partner, it's so important to have a purpose for the stories that we're sharing. The opportunity to share allows us to listen, honor, and learn from those who have experienced care in our healthcare system. It could ideally inspire ideas for change. We can learn what's working well, what's not working well. And it could also promote healing relationships and really activate principles of person-centered care. And by person-centered care, we refer to things like respect, dignity, communication, information sharing, and collaboration. So we use the term person-centered care all the time, but it's really about creating the respectful, open dialogue and partnership with our patients and families. Next slide. So there's foundational principles of storytelling, and Healthcare Excellence Canada is developing and has developed a lot of resources in this space. And I invite people to visit their website to stay apprised of what they're building in this area, including some members of our panel are here today who have been involved in developing these resources. Again, so important to have a clear purpose for the story, and that the locus of control is with the person that's sharing the story. So, if you find yourself in a position where someone has asked you to share your story, it's really you're in control of accepting or declining that opportunity to share. You have the opportunity and should have the opportunity to choose the format that you want to share. Is it live in person? Is it over Zoom? Is it through a letter? Is it through a video? Would you want to be involved in follow-up discussions to learn about what is happening as a product of sharing your story? Do you want to be involved in activities that intend to maybe address some of the challenges that you identified in your story? Maybe there's co-design activity or healthcare improvement opportunities, and also how you'd like to be recognized for your contributions. And so Healthcare Excellence Canada has many more resources. These are just a couple of points on what they have shared in terms of best practices. Over to the next slide. There's also the facilitator. So, and Lisa, who is on our Hawthorne Twait, who's on our panel, tells us about, and she'll tell us more about the role of the facilitator. So it's not just the people sharing the story and people receiving the story. There's an intermediary, there's a support person ideally that is helping the person sharing and the people receiving the story. The role of the facilitator would be to recruit patients and families who may share their stories, help them prepare for the session, promote a safe environment for ongoing reflection and group discussions, provide evaluation tools, liaise with all parties, all participants in sessions to reinforce the learning, discuss further opportunities, and also see if people need resources. It can be a very emotional experience for everyone in the room. And also to follow up and check in and provide those resources for people who share and receive their stories. Next slide. And she notes, and I quote from Lisa, "A well-prepared and skilled facilitator was reported by storytellers to be a source of comfort and confidence as the session unfolded. This individual must be able to create a safe environment to support open dialogue in a productive way, responsive to the person telling the story and his/her unpredictable emotion, as well as the audience receiving it." Next slide. So now we're going to do a little interaction together. I invite people to go to www.menti.com from your phone or from your computer and type in the following code: 67500698. And yes, I can share the slide deck from today, and also the recording will be shared. I just see the pop-up in the chat. When you go to Mentimeter, and Michelle's going to put that up on our screen, you'll see two questions that will prompt you to think about, and you can put in as many open-ended responses as you'd like, about some of the risks and some of the benefits of sharing stories. And the code will come up as Michelle launches the Mentimeter, and then we can put it into the chat. So she's starting to share her screen, and as she launches the Mentimeter, we'll get that code back up. And the code is 67500698. And thank you for sharing these responses. So some of the benefits is being heard and validated, making meaning from difficult situations. Stories reveal the emotional side of healthcare interaction, exactly, connecting with others, making a difference, quality improvement, empathy, giving the statistics and numbers real voice, absolutely, having your experience heard and acknowledged, learning where there may be opportunities for improvement. It's a great opportunity. Connecting with others with similar experiences. So yeah, learning that you're not alone, understanding others' experiences, walking in the shoes, looking at possible solutions. Fantastic. And keep those responses coming, raising awareness, help to improve healthcare system. Catharsis and a sense of purpose, meaningful dialogue. Yeah, humanizing, reducing stigma, understanding. Yeah. Keeps a person-centered lens when making decisions and implementing change. Absolutely. Being heard, building confidence on the journey to recovery. Fantastic. We will move to the next question just in the interest of time, but please keep these responses coming. This is really helpful. Here I'm hearing and seeing the emotional side and the points of connection that could happen by sharing stories. However, what are the risks? Let's think about what are the risks. You may have experienced this yourself, or you might think about what could potentially happen for the person sharing as well as the people receiving, not being believed, feeling vulnerable, opening old wounds, reliving trauma. Yeah, I've seen trauma a lot here. Vulnerability, negative responses, no one listening. Yeah, re-traumatizing, absolutely. Feeling of regret. Emotional triggers. Yeah, it's very risky. It's risky for the person sharing. It's risky for the people receiving. It can be overwhelming. Yeah, I'm seeing trauma come up quite a bit, which is a good segue into the slides that I have a couple more slides to share before we launch into the panel. Being taken advantage of, information being used inappropriately, used for grant funding. Yeah, sometimes we kind of appropriate the story and create, use it to create something or try to show impact in a way that maybe not being meaningful for the person who shared. Bias and judgment could be triggering other people if it isn't shared safely. Yeah, those listening may be triggered. Yeah, no support for those experiencing trauma. And also notice and wanted to point out today, just even talking about this topic, even though we're not sharing our own personal lived experiences today, I appreciate that digging into this topic could be hard for many of us. And I do invite people to, Michelle will put my email in the chat. I'm happy to arrange a follow-up, a smaller group discussion to just check in and see how people are feeling about the session today as well. So I want to offer that up as a follow-up. It's something that within your care teams, you'll want to do as well. Anytime you focus on this topic or share lived experience, you'll want to create that space and that resource for people to connect after, to debrief and to make sure everyone's feeling okay. And if not, getting the resources that in your local communities that can help them. Okay, so we'll stop sharing for now, but do keep your responses coming. And we'll get into this question at the end. And I thank Michelle. She has the hard job of putting the slides up, taking them down, sharing the screen, doing all that fun stuff. And, I heard a lot about, I saw the word trauma come up quite a bit in our discussions just now. And I thank Bev Pomeroy, one of our speakers today, and her colleague, Marika Sandrelli, and I'm sharing their resources on what is trauma. And Bev and the panel will dig into this a bit more. This is more their area of expertise. But here you can see that the definition of trauma has evolved over time. And there's 3 definitions that are provided here. In 2003, trauma is described as an event and a particular response to an event where it might feel overwhelming, fearful, helpless, or horror. And post-traumatic stress disorder is one type of disorder that results from trauma. And then 10 years later, the definition evolved to traumas when we have encountered an out of control, frightening experience that has disconnected us from all sense of resourcefulness or safety or love. And then finally, a broader definition, trauma is an injury or wounding from colonial violence that can be multi-generational and encompass historical grief and loss that's carried over time. Next slide. So trauma-informed practices, when I was looking at the literature, it has been described as well as an approach, a strength-based approach that considers the needs of the person and sharing their story as a whole person. With a context and a history. And trauma-informed approaches, according to Goodman and Wilson, encompasses 6 key practices. So promoting emotional safety of the person, making sure they have choice and control, so restoring that choice and control, facilitating connection between themselves and others, supporting and enhancing their methods of coping. So if they're sharing their story, checking in, providing resources, learning how they're feeling, responding to their identities and context, including systems of oppression and marginalization, so the communities in which they're embedded, and building upon their strengths and openly acknowledging their strengths. Next slide. And again, thank you to Bev Pomeroy and sharing a reference from her colleague, Marika Sandrelli, on trauma resilience informed practice principles. And I won't spend a lot of time here because I do want to get to our panel. And there's core principles that are outlined here to think about as you're learning about trauma-informed practice going forward. It's about awareness. It's about safety and trustworthiness. It's creating opportunities for choice, for connection, collaboration, strength-based skills building and empowerment, decolonizing practices, and meaningful involvement of people with lived experiences. And they sound very broad and conceptual. We will dig into what does this mean for us, as working and being recipients of healthcare. Next slide. And, to bring it down to a practice level, trauma-informed practices is creating a safe and welcoming environment by supporting people to prepare their stories if they do choose to share them, as well as preparing the audience, knowing that this is very difficult emotional work. We can share power through making decisions together. So you shouldn't just have a story shared. It should be tied to a follow-up activity, things that you'll be focusing on in terms of your improvement work in your sector, your community, or your organization. And with the person sharing their story, it's important for them to understand and see the impact of what they've shared and how it's influencing activities and priorities, not just to have them come in and then leave a meeting not knowing, what difference did it make and why did I open myself up? What does that mean? And also to identify the strengths of the person sharing and giving them autonomy in how the story is used. And next slide. And I think with that, I'm just going to jump into our panel. There's lots of content there. We're going to dig into it. I'm so excited to have the honor of facilitating this panel and the amazing group of speakers that we have here today. And what I'm going to do first before we dig into our first question, and again, I do invite people to put their questions into the chat box. I'm going to introduce each of our speakers today, who we're going to dig into this topic together. Lisa Hawthorne-Twait is a patient and family engagement leader. Her joy at work is collaborating with patients, residents, and family partners and integrating their ideas for healthcare system improvements. In addition, she is proud of her achievement in acute care, researching and co-developing a patient experience storytelling workshop and health profession curriculum. Her work, preparing patient and family storytellers as educators, has provided lessons learned and new insight into the value of compassionate person-centered care for audience members. She commits to ongoing learning about ways to support patient partners' well-being and their complex roles. And equally, she cares about the experience of the health professional, and when working together, we create meaningful change. And I've learned so much from Lisa, who's provided generously so many resources in helping us pull this session together. And it's just been such an honor to work with Lisa on this. Lori Malton is a patient experience partner at Blue Water Health in Sarnia, Ontario. She speaks frequently to health professional audiences about her lived experience as a cancer patient over the course of 25 years, focusing on the importance of patient-centered care. She works as a team member in patient experience storytelling workshops, supporting others in transforming their illness journeys into impactful, well-crafted stories where they feel safe and confident to share. And again, learned a ton from Lori, in someone who's been so open in talking about her experience as sharing stories and helping other patients and families do the same. And Emily Cardo, who I have the honor of working with at the University of Toronto, is a PhD student in health systems research and academic partner with a group called Equity Mobilizing Partnerships in Community, which we're going to learn about in our next session on equity, diversity, and inclusion. And that's based at Women's College Hospital. And Emily is an absolute rock star in this space, and such an honor to work with her. And last but not least, Bev Pomeroy is an active patient partner, queer researcher, an award-winning patient public engagement specialist, and an uninvited settler person on the shared traditional, ancestral, and unceded territories of the Nanaimo territory, also known as Gabriella Island, British Columbia. Bev has a particular interest in justice, equity, diversity, and inclusion, and has co-developed a trauma and resiliency-informed practice program for research and evaluation, a strength-based approach to patient and client engagement. Bev landed in patient-oriented research after her daughter, Sophia, passed away in 2017 from a rare complex chronic disease at the age of 16. They sit on the board of BC Patient Safety Quality Council Oversight and Advisory Strategy for Patient-Oriented Research Evidence Alliance and the Canadian Association for Health Services and Policy Research. And, putting this panel together and learning as a group has been just phenomenal. And, this group here, and many of you who have joined us today, have so many experiences and insights to share. And I'm just so grateful to be able to facilitate the conversation that we have today. And so I do have some questions prepared, but I do invite people to put their questions in the chat. And then we'll get into the breakout rooms after. So you can actually stop sharing. Perfect. Thanks. And Michelle can read my brain. So, I kind of threw a lot of information out there to set the tone for today so we can get some foundational thoughts going. But, I wonder if someone on the panel wants to open up with, like, why let's revisit this again. Why share a story? So what's the purpose? Like why even bother? You know, if we're having a meeting or a working group, like why share a story? And Lisa, it looks like you want to jump in, so I'll let you jump in.
I did unmute. If you don't mind, I'll start. And Carrie, I just want to let you know how gratifying it is to be here today and to work with the panel. Thank you to all of those who organized us to have this time together. And I also want to acknowledge the people who've had negative experiences and really tell you that your stories matter. And this is what has motivated me to work harder and to collaborate with lots of different people over the years to really advocate for effective engagement practices, especially when it comes to using lived experience stories. So I come from the perspective of educational purposes. So using and partnering with patients to help me deliver curriculum for person and family-centered care. So I do know there's a difference that was identified by Carrie, and I saw it in the chat. So just know that's where I'm speaking from. When patients and families are prepared to think about what they want to share and work through the experiences that matter most to them, we do witness really firsthand how these stories create those intimate conversations in a curriculum, in a workshop, quality meetings, retreat days, conferences, you know, orientation curriculum. Stories are very powerful in all of those settings. And, you know, they really connect us, sharing human experiences. And by doing that, you're enriching learning for the people involved, and you're motivating people to learn. Again, I've seen firsthand how we've supported a team in goal setting, right? It's been launched by, you know, purposefully sharing stories that we know were very important to the overall improvement of many others. And it can be, you know, so impactful, but also really fun and a really great way to teach therapeutic and communication skills. So I just can't say enough how important stories can be in the role of a patient partner. I mean, that's what people are hoping to do, to use their experiences to motivate and inspire change and hopefully be part of that change. So, you know, I just want to say thank you to all of those people out there, because I know we have many people who've experienced the positive aspects of story sharing. So thanks, Carrie.
Thank you so much for that, Lisa, and for highlighting the educational opportunity that we have by learning from people and the experiences that they've had in the healthcare system, and the positive aspects of it, by being able to connect, to learn, and improve together as we work together. And I know that you've worked really closely with Lori over the years, and you've been sort of a tag team doing lots of these workshops and stuff together. And Lori, we have so much to learn from you in terms of, you know, the patient partner perspective on what it's like to share the story and what others should keep in mind. So my question to you is, what do patient and caregiver partners need to feel supported in sharing their story? So they might be contemplating, should I share, should I not? What do they need from your experience to feel supported, to be able to go out there and share a story in a group setting?
Thank you. I'm just playing with screens here. Sorry, give me a second.
No worries.
I don't know what happened. I also want to thank you for the opportunity to be here. I see some familiar faces in the audience as well. I'm also amazed at how many people have had experience with either sharing a story or their illness journey or hearing a story. I'm going to talk about what I personally need. I do not necessarily reflect every part of the population, but I just wanted to highlight a few things. What I really, really need is to feel completely powerful in my storytelling in terms of what opportunities I accept, what opportunities I turn down, and I need the power to ask and receive all the support that I feel that I need. And that might depend on the situation. I need to feel heard, and I feel it's really important for me to have my story valued. I need, as has been expressed, I need to understand why I'm being asked, and I need to feel comfortable that it isn't just a break for people in the room to hear a story. I need to feel comfortable sharing my journey and reshaping that in the way that I want. And I need to make sure that I have somebody, a facilitator, Lisa in my case, to support all my questions, support all my concerns, somebody that I can turn to for help and support before, perhaps during or after I share a story. I need to prepare myself emotionally. So I need to prepare myself for silence, which is a common occurrence after you shared a story. And I'm just going to share a couple of things that I need from the audience. Confidentiality is really important to me, and I'm sure to every storyteller. It's really important to me that myself as a storyteller and anyone that's listening to the story celebrate the fact that we're all there trying to learn from one another and to share information with one another, and that the audience is there hopefully to learn from my experience. I need to make sure that people are not being judgmental. It's so easy to dismiss a story by thinking about what a person did, maybe that contributed to their medical issues, like not wearing a seatbelt, drinking too much, eating too much. I think we're there to support one another, and I think it's really important to suspend all of those judgments and to know that there is not going to be judgment from the audience about my story, or the reverse of me judging the audience from the comments that they make. Just one last sort of lump comment that I want to make. There are a couple of things that I just wanted to caution people that are listening to patient stories or caregiver stories. There are a couple of things that I find difficult to listen to, and they are comments that are overly positive. And I think there were some mention of this in the initial workshop. So people that talk about how great it is that maybe I'm still alive, that maybe that I got healthcare, we have free healthcare. All of those things are true and important, but it, for me, diminishes my story. It kind of shuts down my ability to share, and it's a sort of a silencing thing for me. It's really important for me to not have, or what I want the audience to think about is talking about gratitude. I think every patient is very grateful if they're there to tell the story. They've survived their illness journey, but overly emphasizing how grateful patients and caregivers should be is hard to hear. I think everybody is grateful, but again, you can be grateful at the same time as having some thoughts about how things could have been improved in your healthcare journey. And lastly, the topic of bravery, which for me is surprising. I come from a culture that doesn't put a lot of value in bravery, stoicism. I felt really comfortable being emotional and needy and railing against the injustice of my medical experiences. And I just think asking people to be brave or congratulating braveness puts an undue burden on patients and caregivers. That I think that's a choice for people, patients and caregivers to make, not something that should be asked of us. And that's all I wanted to say.
Wow, Lori, thank you so much. My brain is buzzing right now, and I saw lots of comments come into the chat. And you know what you're talking about, it really makes me think about the last session we had on empathy and what it means to provide an empathetic response. That sometimes we want to lean in and like fix or say, oh, it's not so bad, or oh, good for you. But we really need to show up as listeners and be curious and ask questions. And it sounds like that's what you need to feel supported. So I do see the linkages between the different sessions that we're having. And you provided such a great kind of overview of the different things that you need. And as you identify the things that you need, I look again, I know we have a broad panel, but I am going to look back to Lisa again for a moment, who facilitates these types of sessions and teaches people how to support patient and family partners. And Lisa, you know, when I think about the role of the facilitator and meeting people that are leading meetings and bringing people in to share their stories, what can they do to create the safe space? Because some people might not know how to listen to a story in a way that's supportive. And Lori pointed out many ways where she doesn't feel necessarily supported. So how can we help people learn how to be part of that safe space and what they can actually do, what their actions can look like? And so I'm just going to flip back to you before we move on to some other members of the panel.
Thanks, Carrie. There's so much to talk about in that regard, but I'm going to pick one thing, and that's the planning process. So again, starting early in the planning, who the leader is of the audience that you're presenting to, who the chairs of the meeting are. I like to work very closely with them and the patient partner prior to a session, aligning goals, developing rapport, helping that person be a support in the room as well, because they're the leader of the group, and they have the greater influence in terms of modeling patient-centered leadership, in conveying the value that the person has coming to their meeting. So I kind of like to coach that person as much as I have developed my skills over the years. It really is about, you know, how that person supports us coming to the meeting or the workshop session. And I think by doing that, you're creating trust, you know, within that relationship. The leader of the audience. Also, that allows the person, if it's not myself, say the nursing leader, the medical director, it allows them to know the patient story, and then they can also facilitate it well. If they're not, taken off, like having surprises, in a meeting, I think they can do a better job of helping facilitate the questions to the audience, making the linkages. So it really is just about that, again, focus, shared goals that the patient partner has with that person, that they feel comfortable. And then how we introduce the speaker, right? Really setting the context. We've all been in meetings, like just standard, good, effective meeting management. You do proper introductions, and you make people feel comfortable. You ask for the door to be closed. You ask for presence during the share, to please, put your cell phones down. So those are things that I've learned to do over time, and really acknowledge publicly the very significant opportunity, that we have today with the person's willingness to share with us, and expressing that gratitude. And in your workbook, we give you a few ideas if you're a facilitator and how to open a meeting. So you're really setting the tone. You might talk about confidentiality. There's so much planning and thoughtfulness that really should go into it for it to be successful. The other piece I do want to say, in terms of safety and effectiveness, I feel like patient partners feel a good outcome when they're able to have a conversation. If they're going in and leaving, that doesn't feel like engagement. And they then leave feeling, I saw someone use the word shame. They might have that kind of thoughts about maybe I shouldn't have said that. But if they can participate in a dialogue around the concept that they're, hoping to convey, they can hear and feel the impact their story had before they leave the room. So that's another, I think, psychological safety element. The dialogue or the planning, action planning, conversation after the story sharing is a way of supporting that person's experience.
Thank you for sharing that, Lisa. And, you really noted a lot of like the preparation that's required of the facilitator with the patient family partner and also with the audience to create the best space possible for the sharing of the story. But I do wonder, it got me thinking about, you started to get into a little bit of the risks, when we don't create that space, what can go wrong? And I'm going to look to Emily now, another member of our panel. And Emily, can you dig into some of that? So like, do patient and family partners have to share their story? Can you get into some of the risks and some of your reflections related to that, the risks of sharing stories?
Yeah, I think that's a great question. My sense is that there's often this sort of unspoken expectation that patient and caregiver partners have to share their story as part of the work that they do. I would challenge that by saying that ultimately it's for every individual to decide when, if, how, ultimately they share their stories. And, ultimately whatever that person decides is the right choice. We've talked about some brilliant, benefits to storytelling and sharing our experiences. But we also talked about some of the risks. We can't deny that there are, power dynamics inherent in our relationships. It can be very vulnerable. It can be very emotional. And it can feel especially difficult when the vulnerability that essentially you're being asked to share is perhaps not being reciprocated. So I guess I would leave that with just a word of caution that ultimately whatever you choose to do is the right choice, and you have that agency and choice to choose when and how and if, with whom you share your stories.
Thank you, Emily. And, as a bit of a follow-up, I wonder, people come in with like a very likely a long trajectory of experiences and things that have happened throughout their interactions with healthcare. Like, what parts of their story do they share? Like, is there some kind of strategy that they put into this, or like, how would you guide them in? Like, what do they share, and how do they figure out what to share?
Oh, I feel like that's again an individual question that each person's going to answer for themselves. I think that again, there are times where perhaps you feel comfortable sharing more, with particular audiences, particular people you know and trust, and you've already built that foundation of trust with. And then there might be other times where you share perhaps another dimension of your story, or even another version of it. It doesn't always have to be the same story every time.
Thank you for that. And, I remember a past conversation we had when we were planning the session, and because we were so focused on the planned story, like you have a meeting agenda and you have identified the patient partner and you do the preparatory work, they come in, you prepared the audience. But inevitably, sometimes, and probably many times, we find ourselves in situations where just based on how the conversation is going, without planning, a story is shared. And so what does that look like? And like, what do we do? Like, what if a story is unplanned and it sort of just organically happens in a space that we're sharing together? What should we be aware of? What could we do as listeners? Can you kind of comment on what that looks like? So I think we've all probably also been in situations like that where it's a bit spontaneous and it might catch us off guard.
Yeah, I'm sure I'm not the only one who's been in many situations where the moment is right, and folks are sharing their experiences in ways that were perhaps unplanned. And I guess my advice would be predominantly directed to listeners or the folks who are receiving those stories. If someone feels safe enough to open up about their personal experiences, it's really on everybody in that space to give that person their time and their attention that they deserve. And I've seen this modeled by some of my mentors. Really, it can sometimes mean throwing the whole meeting out of the window. And that might sound like simple advice, give someone time and attention. But when we think of how we often structure our time together, we might spend, weeks planning a meeting, scheduling a meeting. We build agendas that are sometimes, scheduled down to the very minute. But ultimately, at the end of the day, the work that we do is all it's all founded on this basis of trust and relationships that we're building with each other and accountability to each other. So it means really being flexible and putting everything else aside and making time for each other. And if someone has felt safe enough to open up and share, you give that person the space and attention that they deserve.
Thank you for that, Emily. And I could totally resonate with like all the planning that we do down to the minute. We have an agenda. We feel compelled sometimes to tick every box that we have in the agenda. But as people in working or receiving like health services, and we're ultimately there to work together, support people, and provide and give quality of life where we can. It is about creating that space and letting go of that structure sometimes, which is really hard to do. And so thank you for highlighting that. And we need to give ourselves permission to stop and take a deep breath and to listen and to really connect. And finally, getting over to Bev, I have so many questions for you, Bev. And, I'm so just impressed with the work that you've done in trauma-informed practice and resilience. And, I've learned, again, like just so much on this topic, after working with you, and we've worked on other projects as well. So I feel very, very honored to have that. But I'm thinking a little bit more about the audience perspective here and how your views on how we can best prepare people thinking about those trauma-informed practices as well. Like, how would you, like I said, in a practical sense, where do we start? How do we create that space? Because we talk about creating safe, comfortable spaces. And even myself, sometimes I walk away and I'm like, but what does that actually look like? What does that mean? And so I wonder if you can take us kind of through some of your thoughts on that.
Yeah, thanks, Carrie. What a great conversation. And I know we've had some prior to this. I'm always blown away by the breadth of knowledge and experience here in this space. So, when it comes to someone who's maybe hearing a story, of a family member or a patient, I think the number one thing we need to recognize, which I don't think we really talk about very often, is we have trauma organized systems. There's a lot of what Dr. Sandra Bloom is doing right now, that our systems are organized around trauma. So when we're coming in and sharing our story, I come in often and share my story about Sophia and our experience. I'm walking into an environment that is already traumatized. The system is organized around trauma. So I think for those that are listening to our stories and that are sitting in that space, number one, you are already in a trauma organized system. So there are some things that we've developed with the trauma resiliency informed practice programs that we're developing in BC around mental health and substance use in particular, really looking at how to set up that space. And I think Lisa and everybody prior here, Lori, has talked about it. And it really is about that activating resiliency piece within that audience, knowing that you are going to hear a story that might be challenging. And what we talk about is this window of tolerance. And I think those of us that are patients and patient partners, we know our window of tolerance when it comes to point of care, when someone sort of pushed us out of that window of tolerance. And I think as an audience, again, having that choice and control to say, what, this might be really difficult for me to hear. I've had a child that's been sick. I need to leave the room. Give yourself permission and the choice and control to leave the room or turn off your camera. I've seen some comments in the chat box, to have that choice and control as an audience as well, to understand that you may be activated within your own experience. Maybe you've had an experience with a patient that's similar and now it's activating that within you. But again, to have that choice and control and activate your own resiliency and know what your window of tolerance is when you're listening to a story. It's not to say that you're going to be rude or offensive or say things back, to that person. But again, give yourself permission, know what you need within that window of tolerance to listen to that story in a meaningful way that's going to, hopefully impact the work that you're doing.
Thank you, Bev. And something was brought to my attention in the chat, and I wondered, I'm going to Laura, I wonder if you can speak to this, and I'm just going to read it out loud, and yourself or anyone on the panel could respond. And Laura, I hope it's okay that I'm reading this out. You said, one of the things that I find challenging when personal stories are shared is that an emotional space is created, And the oscillation balance between being in an emotional space and a rational space might be challenging for meeting and gathering participants and facilitators. I wonder the value of opening up this emotional space and then pulling participants back into a rational space for the operation of the meeting. I'm missing this understanding and therefore the knowledge of how to facilitate between these two spaces, especially in a time dictated meeting agenda. And kind of like aligns with what Emily was saying too, is like, how do we, it's true, like we do kind of move kind of back and forth, and can you bring these spaces together? Yeah.
I'm going to kind of speak to that a bit. And again, I think a lot of it we talked about at the beginning of this sort of conversation. A lot of it is that prep work. It's being aware that we're going to have these conversations, whether they're on the books as an actual conversation about someone's experience, or it happens chance someone's bringing up their own experience in a meeting. I really just think it's safe to say that we are going to be activated. The trick is when we are activated, then how do we keep somebody, ourselves in particular, within that window of tolerance, so that we feel safe, we feel connected, we feel cared for in that moment. And that really is a conversation to have, even around the facilitation that Lisa was talking about, is having some of that invitational language in that moment to Lara, like what could help you feel safer? What do I need to do to avoid that you might cause activation? It's that invitational language and really stopping that meeting and everybody being present. I mean, we're huge supporters of the work that we do around mindful self-compassion. And I think if we're going to be facilitating these conversations, then we need to have a really strong mindful self-compassion practice so that we can sit in that ourselves and be able to support the people through those conversations. I also feel might be a little bit prickly for people, but I also feel like we have existing engagement frameworks and maybe participation frameworks that are oppressive or are going to continue to oppress certain communities. We look at some of our funding models and our convening grants. They give you 12 months to convene a group in a community that maybe has had historical trauma. So again, it's sort of back up a little bit and giving yourself the time and the resources to be able to do this work really, really well. And then ideally, we're not going to hit up against some of those walls that we currently are experiencing.
Thank you. Thank you for that. And I'm looking at the time, and I want to make sure we have audience participation as well. So Michelle, did you see any questions come up into the chat that we could dig into?
I'm just going to go up. There's a lot of comments. I'm just going to see in terms of questions.
And as you look for questions, I wanted to highlight some conversations I had with Irene Wright and her colleague Desiree Doolittle. I don't know if Desiree is here today, but I was able to learn with Irene from Desiree's work about like feeling triggered versus feeling uncomfortable, and trying to kind of differentiate what it feels like and what it looks like. And I wondered if anyone on the panel could talk about, are you able, if someone is triggered, are there signs that we could see and look for that would kind of alert us to, okay, someone in this meeting is not, and it kind of speaks to those windows of tolerance, I think, that you're talking about, Bev, trying to recognize what are our boundaries. Like, can you tell if someone's been triggered and recognize that in a meeting, and what might that look like?
I think, Carrie, yes, you can tell when someone's been activated, but sometimes you can't tell when someone's being activated. So, but the possible signs of reactivation, and I think we can see it. People can see it with me. I'm a good Irish girl, so I get all red and blotchy. So I become sweaty, or change in my breathing, or stiffness, or you'll see somebody actually disconnect. So if you're in a meeting at a board table, I think some of us probably have had those experiences where you'll know right away, okay, that patient partner is just disconnected from the conversation. They've been activated. So again, it's just being really mindful and being aware. And if you have somebody on your team, and that facilitator person who's so important that Lisa's mentioned, is that person sort of being engaged with that patient partner so they can recognize, when that person has been activated. And again, so that conversation ahead of time is, what do you need in that moment? What can we do to not activate your trauma? It could be around language. We know in mental health and substance use, there's a lot of language that can activate trauma, in that experience. So again, looking at language and changing language that we're in that group. But, again, becoming disconnected, staring off into a distance, again, like myself, being mottled and blotchy. So there are definitely signs you can tell when someone has been activated.
Thank you for that. That's really helpful. And I just wanted to reflect on this whole panel discussion is, we started off the conversation by talking about, sharing and receiving stories as an educational opportunity, as an opportunity to learn what's working well in the health system, what's not working well, as a point to focus on for our healthcare improvements. But then we also moved into, you don't have to share your story, that the autonomy really lies with the person who might have that opportunity to share. It's about reflecting yourself on, do I want to share? What parts do I want to share? What do I need? And how do I articulate that need to the facilitator? And in the workbook, we provide some tips on how to do that. But also, most importantly, as an audience member, our responsibility to put our cell phones down, to put our videos on, to really listen and take in the story, and in a non-judgmental way, which can be really hard. We might not agree, or we might have feelings about what people are sharing that don't necessarily align with our values or how we think about things. And it's about putting that judgment aside, creating the space to really listen, to be open, to be prepared with questions so the person feels validated. And also, as Bev was talking about, kind of recognizing if someone has been triggered and how to respond in a way that's empathetic, and recognizing body language and things that might be happening, and providing some follow-up conversations, checking in with one another, providing resources. And Bev generously provided a template for a resource that they use in BC. Whenever they have an event involving patient, family, community partners, all participants receive this resource, and it has phone numbers and websites and contacts that people can have, and also some tips on how they can prepare and participate. So every Ontario Health team and organization might have, but should have, something to that effect to share with people so they can learn how to participate and feel safe, and also connect and get some emotional support afterwards. So with that, I think we're just a few minutes over time. So I think I'm going to do a quick little scan of the chat just to see if there's anything else. I think there's a
question
lot
that
of
just
comments.
came in.
Okay, if you want to read that out, we have time for that.
I think I have one or two. So if you don't mind, Sabrina, I'm just going to read yours out. I'm wondering if it's possible to dig a little deeper into supporting the person sharing and knowing whether or not they're ready to share. On an awareness day last year, we had someone offer to share their experience with grief on stage in front of a large audience. She had never shared publicly before. I had concerns with her preparedness to share her experience in such a grand way, but I also had to trust that she was ready if she was ready. Oh, sorry, I thought there was a question in that, but great comment. Does anyone want to speak to that?
I could just add a comment. I've had people who were concerned themselves and weren't sure if they were ready. Practicing has helped them, but also if they do have a counselor or family doctor, someone who's been supporting them, using grief as an example, I've asked them to speak to their health professional about the impact of sharing their grief story, if that was seen as therapeutic or if that was seen as a risk, and get that feedback from somebody to help us decide if it's appropriate for them and their well-being.
Thanks, Lisa. And I think maybe we'll go to Wendy's question that just came in. She said, when we participate in a meeting, we are there to provide input from our perspective. Often our input was received with a polite acknowledgement and not really taken seriously. This makes us feel discounted. However, in a meeting with a tight agenda, we don't feel it is time to be brave and call it out. What is your advice in a situation like this? Because I think, Wendy, you're right. I think that will continue to happen, is people will create like a window of time and then move on. And it might not feel good. It might not feel that the story is being taken seriously. So I wonder, as people who are designing these meetings and agendas, what do they need to keep in mind? Anyone?
I would say, yeah, I would say, again, we've created sort of these frameworks and these ways of being in engagement that do not provide the space and time that we need to nurture those conversations. So I would really encourage healthcare professionals that are engaging with families to try and create more time. And I know that's a funding issue. I know it's a resource capacity issue, but I'm hoping over time that we start to do that, because we do need more time to engage, particularly with hardly reached communities, when we're trying to build trust just to get to a story to help impact their experience. So I think there's a lot of work that we need to do to get to that. But I think in that moment, so what we do in the work that I do is I always make sure that I follow up with whoever I'm engaging with, whether I'm engaging as that patient partner or I'm facilitating and leading that conversation. There's a lot to say around social trauma. It's one of those things that's not talked about a lot, but our experience often stigmatizes us in the healthcare system, especially if we've experienced healthcare harm. And as we're sharing our story, we become even more stigmatized. So again, minimizing that social trauma, and that's really around predictability, choice, and creating those connections. And again, I keep referring to it, but I know for me, when I'm sharing my story and when I know that it's going to have an impact, I have clarity of expectations, I have an opportunity to contribute, but I have a caring, connected relationship with someone on that team that I can engage with after. I think that's really, really important, that connection piece and that caring, connected piece to help abate some of these challenges that we do, and we are inevitably, going to experience in sharing our stories.
Thanks, Bev, and just really highlighting, having that go-to person, having that peer, that someone you can connect with to help you navigate the feelings, the processes, and all those pieces. I'm going to go to one more question from Michael, who said, what about when you are recorded and perhaps posted online while sharing your story? What are your rights to control the use of the story? Would anyone like to comment on that? Lori? Oh, you're on mute.
Yeah.
There we go.
I think that's part of the confidentiality agreement or the consent that you are comfortable with, that you share with whoever is facilitating prior to the meeting. So all of that information should be shared with you before, and prior to your sharing, you should have the ability to ask all of those questions and say, no, I'm not comfortable with the recording, or I'm certainly not comfortable with the recording going, for instance, today, this is for OHT members going outside of that platform. So connecting with that person, that supportive person, again, that facilitator role is so important, and we keep circling back to that, making sure that you have all the information you need and you know what you're consenting to and what you're not consenting to prior to agreeing to share a story.
Great, thank you. Thank you for that, Lori. And it's always hard to bring a really great discussion, which is gaining momentum, to a close. I am mindful of the time. I do want to thank, just reminding everyone, if you can mute your microphones, that would be great. But just want to thank our panelists today for helping us dig into this topic to get started on a really important conversation that I'm hoping everyone will continue with your teams. We do go or the main room. Is that it? And I want to apologize. The time went by so quickly. If people have to leave, no problem. We're going to just try to wrap up the discussion, and you can go back and listen to the recording after. I do want to just do a quick kind of tying up of loose ends so we can just have some crisp, like, take-home messages for the full group. And if our facilitators and co-facilitators are still with us, I thought we'd do a quick roundtable just to share some highlights from the breakout rooms that we had. And so I can go first for my breakout room that I co-facilitated with Lori. And I know people are coming back. So if Junie, if you can close the breakout rooms, I think about 50 seconds will have everyone back.
They've been closed, so they should be coming back.
Perfect. So people will be joining us.
We didn't get to finish.
Perfect.
Sadia was just about to talk. Oh, well, Sadia.
Okay, so what I'll do, I'll start, and then maybe Sandra, I'll hand it over to you next, and apologize for going a little bit over time. But a good key point that came out in our session is we really focused a lot in the conversation on the role of the facilitator, and people shared what it was like to work with a facilitator that was really effective. And one example that was shared was a facilitator would meet with the patient partner with the full slide deck that they had for that meeting. and they would review it together, and the patient partner was able to see, like, this is the focus of the meeting. The facilitator was able to run through the slides, and it really helped the patient partner figure out where to focus their story based on the broader context of the meeting to make it as impactful as possible. So really great strategy for facilitators is to be cognizant of what is the main purpose of the meeting. Is there a good fit with the patient partner? And then work with them to help them pull elements of their story that really align well with the meeting for maximal alignment, and also potentially maximal impact from sharing that story, so it's not as disconnected. So I'm just going to leave that as kind of one of the nuggets that we shared, and then over to Sandra to share. For those that are coming back into the main Zoom room, if you have to leave, that's okay. We'll have this recorded. We're just doing a quick roundtable of key points from our breakout rooms. Over to Sandra.
Yeah, so in the time that we had it there was a gentleman who's a teacher and he's done work for 25 years. He indicated about, having more time to get to know the facilitators of this course and the people, of course, not, but I gave him the answer to William was that, this unfortunately 1 hour and a half doesn't allow us to do that, but we definitely would like to see something like that. And I told them about the OHT PFC meetings that we have where it's an open chat. And then Betty Lou brought up a big thing too, because it was based on the comments that were in the chat about the sharing of the story. And so when the one person had indicated about like the timing of meetings, Betty Lou pointed out like today's about stories, and my experience, I was talking about lived experience. So it's when we're telling those the differences, right? But even someone else explained about when a lot of it goes back to now about meetings. So like, even if the person so I'll use my example because it's like, so if we have on an agenda 5 minutes for patient story, and I've got it to be changed to patient experience, because 5 minutes isn't for patient story. And so it's like, something that happened recently that would help the team, right? So if it was an experience I had at the ER or with a doctor or whatever, or I finally got a family doctor in Muskoka, sometimes some of the things I've shared are vulnerable, right? But it's sort of like there's no time space between me sharing that and then then it's like next, right? And so it's not good. So then other people have said where primary care providers shared a story and they were able, they shared the story and how the patient felt, and then justified the emotions of the patient. And they're excited, and that really bothered them. And then we had the conversation, should have I said something? And then another person started talking about that. And then another person said, we have a proper facilitator who would say, is there anything else to add? And unfortunately, I didn't get to my friend said, yeah. But that basically, my feedback to them was the fact that you felt it. Maybe you could, but sometimes you have to pick your battles.
Right. Thank you, Sandra. So quick comments from Lisa and then group 4, and then we'll do a quick wrap up. And apologies for those who, and please leave when you need to. You'll capture the recording after. Lisa or Michelle from room 3.
Yeah, I can jump in really quickly and I'll just keep it really short. We had like a great few reflections. We just kind of talked about what really resonated from the session today. And so there was just a lot of talk of or some talk about, that piece about the leadership and management, having that buy-in from the top, and really how important that is to have them have that buy-in into, hearing from patients and caregivers and those lived experiences, because that can sometimes maybe affect, initiatives that you are trying to get off the ground. And lots of conversation just around like we need to value and also kind of bring up some of those points about like compensation and time that people are also spending coming if they're being asked to share their story. And yeah, just some reflections on like really thinking about like, are we doing enough to prep both those who are sharing their stories and receiving? So just a lot of reflection about those points that we talked about today.
Thank you, Michelle. Group 4.
Yeah, we had a great conversation. I think it could have continued for many more minutes. We focused predominantly on how do you recruit people to tell their stories, or find, the right people to tell perhaps relevant stories. So we talked a lot about relationship building, the importance of working with people beforehand, the importance of mentorship, coaching. And a really important point that stuck out was this notion that everybody deserves a space to tell their story, and ultimately the role of facilitators is to help find those appropriate opportunities to help people find those spaces to tell their story. And part of that requires longstanding relationships. Part of that also requires clarity of expectations. So if there's an opportunity that comes up, that the facilitator is really clear about what that opportunity is, and they can then connect a storyteller with that opportunity. We spoke about the importance of facilitators in creating safer spaces, and just this notion that you never know what's going to happen. You have to be flexible, adaptable. There's a lot you can plan for, but there's a lot that you just really can't. And then we talked kind of more aspirationally about, this hope that our educational systems will become more trauma informed, that will learn earlier in life how to receive stories more generously. And there's already great advances that are happening, but we hope to see more of them as well in the future.
Thank you, Emily. Such a great way to kind of cap off our discussion. So well said. And Michelle, if you want to flip up the slides really quick, I have a couple of closing acknowledgements to make. And there's so much gratitude for everyone's participation today. There's a lot of ideas floating around, and we're crystallizing it. And as we think about these ideas, it's just the conversation will continue. When you close the session today, you'll be brought to I think we'll skip the Mentimeter, and we'll go on to the next slide, where just to alert you to a survey that you can fill out, that we're hoping everyone will fill out. When you close the session, a link should show up on your computer, but you could also take a picture of this QR code or click on this link to outline your reflections on this session in terms of what worked well, where we could improve. You could always email me as well. Michelle will put my email in the chat if you would like to share with me specifically what worked well and what we could do better on, and what your learning needs are. So again, there's multiple ways to connect to the follow-up survey, and it should show up when you exit the session today. Next slide. Next session, February 21st, on equity, diversity, and inclusion. We'll learn about the impact that privilege and power dynamics have on communication and relationship building, and the value of anti-oppressive approaches to mitigate bias in the work that we do. There's a registration link available to you, and we can also put that in the chat. Please register. And I just wanted to acknowledge in the next follow-up slides, if you want to advance them, all the people that have been involved in this work. And we're just going to kind of fly through these, but lots of members of the research team, the McMaster Rise Network fully supports this as a resource for OHTs, the Patient and Family Caregiver Engagement Community of Practice, the Ministry of Health, Betty Lou Christie and her group, onto the next slide, and many other people that have been involved in the fulsome development of this curriculum, which has culminated into a 7-part series. And it's a labor of love. This has been like the most exciting thing I've ever worked on. I'm being totally honest. It's just, the learning is unreal. And I'm hoping everyone is enjoying it as much as I am. And thank you for your time. Sorry for going over. I'm the worst timekeeper. And it's something I need to work on, to be respectful of people's schedules. But the good thing is we do have this recorded, so you can go back and reflect. Many thanks to all those who were involved today in designing the session. It was no small feat to pull it all together. So many thanks, and please send your feedback. We have lots we can improve on. Hopefully there's some nuggets that stood out and you feel inspired to continue with the work. So with that, I will officially close the session 10 minutes late. And I thank everyone and wish you well as you go on with your days. And please, let's keep the conversation going. Take care.